Hello, everyone. Welcome back. This is our final module, Module 3, Part 2, on thinking critically, interpreting randomized clinical trials. And the objective of this module is to actually, understand how to critically evaluate at RCT. And in Part 2, we wanted to apply the skills that we learned in Part 1 to actually critique the DPP study. So the motivation for this study was the case of Ms. Lorenz, who had a history of gestational diabetes. She also has a family history of type 2 diabetes. She reports feeling fatigued. She's overweight. Her hemoglobin A1C results suggest that she's pre-diabetic, and she wants to know what she can do to prevent or delay the onset of diabetes. And so this paper was relevant to this particular scenario. Now, as we discussed, the initial set of questions are just the screening questions to help you understand what the research question of this particular study was. Was it a well-defined population? What was the intervention and what were the outcomes? And whether the RCT design was appropriate to answer this question. So I'm assuming we all agree that the study met these screening criteria and we want to move on. But I want to show you that I have this trick I do, and I'm sure you all do this too, is I tend to mark up the PDF of a paper, and I actually, will use different color codes, which may not be necessary. But as you can see, the research question is clearly identified in the last couple of sentences before the methods. So this study was designed to answer the following primary questions. Does lifestyle intervention or treatment with metformin prevent or delay the onset of diabetes? Do these two interventions differ in effectiveness? And they also wanted to know whether the effectiveness of the interventions differed according to age, sex, race, or ethnic groups. So I'm just going to go back to our PowerPoint slides here. So the basic design of the study was a 3-arm trial where subjects with insulin resistance were then randomized to either lifestyle, metformin, or placebo, and they were followed over time to see what was the risk of type 2 diabetes in the 3 different arms. So now let's look at the next set of questions, and these have to do with systematic sources of error that might threaten the internal validity. So as we discussed, the first one is confounding. As we see in the paper, yes, randomization was used, and in a minute we will look at Table 1. But the other question we wanted to know was intention to treat used? And so here's a little section of that paper that clearly states that the study design and analysis followed intention to treat principles. So we know that they used the gold standard approach and that people were preserved during the analysis to the arm that they were randomized to, irrespective of whether they dropped in or dropped out from that particular arm. Now, let's look to see whether randomization worked. So this is the beauty of Table 1, where you look at all the baseline characteristics, such as sex, race, ethnicity, family history of diabetes, and so on. And you're looking to see how well were these distributed across the 3 groups that are being compared. Now, if randomization worked, they should be well balanced across the 3 arms. So here we're eyeballing the numbers. Now, because of statistical randomness, you're not going to see exactly the same proportion of males or females in each of the groups. But if we compare the proportions, we can see, the gender distribution is fairly good, and so are the others. I'm going to also focus on race ethnicity, and you can see, wow, they've got so many different groups, but randomization clearly worked because on average, the distribution of the different racial ethnic groups is fairly similar across the 3 arms. So at least with respect to confounding, they did the right things. Their randomization seemed to have worked. These covariates that could be potential confounders are well balanced between the 3 arms, and they also used ITT. So now let's move to the second question. And this has to do with selection bias. So we wanted to know what was their follow-up. And if you look in the methods section, and hopefully you were able to find this as well in the paper, they tell you how many they started with. So they randomly assigned about 3,000. They tell you how many are in each group. And then they tell you something about the follow-up. So participants were followed up for an average of 2.8 years. And at the close of study, 99.6% of the participants were alive, of whom 92.5% had attended a scheduled visit within the previous 5 months. So this study had very good follow-up, and we're not worried about, losing people due to attrition. Also, given that their follow-up rates are so good, we're not really that concerned that, these small, even if there were small differences between the three arms, this question would not be relevant. And so the other questions are really not of concern and do not apply to this particular study because their follow-up was very good. Now, what about misclassification of the exposure? So is blinding feasible? Now think about it. One of the arms is lifestyle. It's hard to blind people to lifestyle. But did they blind people in the metformin and placebo arm? And in their methods under statistical analysis, they actually tell you, so I don't want you to worry about the highlighted portion, but look at this. They clearly tell you that assignments to metformin and placebo were double blinded. So where they could, they did blind, which is excellent. Then I want to know, well, okay, how good was the adherence? And did the researchers measure that? Do they tell you how well people adhere to the treatment? And this is very important for this study because they're going to be using ITT. So in this paper, they do have these panel of figures which help you address the question about adherence to the therapy. So as they mentioned in the paper, in the lifestyle group, one of the goals was to see a weight loss. And you can see here in this panel, the very top part of the figure, that those in the lifestyle group were the ones that had the most change in weight, and they had the most weight loss. Of course, this weight loss, is not that great as the follow-up continues, and this typically happens. But clearly, people did adhere to the treatment because you're not seeing the same drop in weight in the metformin and placebo arms. Likewise, the physical activity levels changed the most for the lifestyle groups, which tells you that, okay, it wasn't perfect, but people did adhere to the treatment that they were assigned to. While you don't see that uptick in physical activity in the metformin and placebo group. So these two figures demonstrate that despite lack of blinding in the lifestyle group, subjects did adhere to the recommendations, although adherence isn't perfect. And we already know that when we study human subjects, it's never going to be perfect. Well, what about the bottom panel? This tells you the number of subjects that adhere to the placebo and the metformin pill. And you can see on average, the adherence is, approximately 70%, goes down, substantially, well, not much less than 65% clearly as the study duration continues. And of course, the placebo group does slightly better. So what does this mean? It demonstrates that adherence is not perfect in metformin and placebo group. So now that we've identified that there is some potential for misclassification of exposure, what we want to know is what is the implication of this imperfect adherence when ITT is used? Well, as we've discussed before, the effect is that we're going to attenuate the relationship between the intervention and outcome. So in this study, what we come away with, we infer that if anything, we've underestimated the effect of both lifestyle and metformin use on reducing the risk of type 2 diabetes. Now, what about the outcome and misclassification, the outcome, and how that might threaten internal validity? So here we want to know what was the outcome. And here the outcome is, type 2 diabetes. Well, I think we would all agree it's an objective measure. People are not self-reporting. It's actually a laboratory-based test that is, coming up with the inference. Was it blinded or not? It's not very clear from the paper, but my guess is they do mention that they do not make the subjects or the investigators aware of these levels unless they tread into values that determine that the patient now has diabetes, in which case you do have to inform the patient. And one would assume, the way the study was done, that similar procedures were used to ascertain the outcome in all study subjects. So here's a little bit from their methods section where they describe the outcome measures, where they tell you that the primary outcome, diabetes, was diagnosed on the basis of the annual oral GTT, glucose tolerance test, which, is considered the gold standard, or the semi-annual fasting plasma glucose. So remember, back then, hemoglobin A1C wasn't something that was being used to diagnose. It was the oral glucose tolerance test. So you can see that they didn't use exactly the same test. So should we be concerned? Well, or what are the implications of the fact that some are getting the OGTT and some are getting fasting plasma glucose? Well, this suggests there's going to be some misclassification because we may not pick up all the cases using a fasting plasma glucose. However, should we be concerned? Well, no. From the way the study is done, it appears that this method would affect all three groups in a similar manner. So it's not like only people in the placebo group are getting fasting plasma glucose while the other two groups are getting OGTT. It appears, for whatever reason, which the authors do not describe, logistics or otherwise, it appears that, these two tests were used across for all the three arms. So what does this do? Well, there is misclassification of the outcome, but it's, again, more likely to result in underestimation of the effect rather than an overestimation. So, how did we do on our checklist for the three main systematic sources of error? So what do you think? Do you think confounding could affect the internal validity? No. It's unlikely to threaten internal validity because they used randomization and they also used ITT. What about selection bias? Do you think that could threaten the findings of this study? Unlikely. The follow-up was excellent, so we're not worried about that. What about misclassification bias? Yes, there is some misclassification of both the exposure and the outcome, but as we've discussed, if anything, this will result in underestimation of the effect. Now, I'll really show you, and I'm sure you do this as well, but I'll show you my little method that I have when I mark up a paper. So let me go to the PDF of the paper, and I won't belabor you through the different, and it doesn't matter what colors you use, but as I go through the paper, I go through the methods section, and I'm trying to see, what are the various portions that point me to the different sources of bias. And so I happen to use, in yellow, things that were related to confounding. So eligible subjects were randomly assigned. This tells me, they did randomize, and they also are telling me that ITT was used here. I then, indicate anything related to exposure, or I guess in this case, the outcome misclassification by going through the outcome measures section. The purple is for the random error part, which we will get to shortly. I then will just show you very quickly. In green, I identified things that were related to selection bias, so things to do with follow-up. And here was information regarding adherence, which has to do with misclassification of the exposure. So if you mark up this paper and you're specific about the threats that you're going after, it's really easy to do this in a reproducible and a consistent manner where across researchers and clinicians, we could also see that these, the way people are critically evaluating a paper can be made very reproducible and objective. Okay, so we're not done yet, so I want to move back from the mark of the paper back to now discussing the random component, and we haven't looked at the results yet. So looking at the results, we want to ask the following questions. How was the treatment effect measured? So did they use risk, rates, means? What was the magnitude of the treatment effect? Are these effects clinically significant? Could random error or chance play a role? So did they do hypothesis testing? And was the treatment effect statistically significant? How precise were these estimates? Did the study have adequate power? Did they tell you anything about the sample size computations? And finally, do we need to worry about multiple comparisons? And if so, how do they approach that in the paper? So how was the treatment effect measured? As we discussed in Module 2, in this case, you should have already predicted that since the outcome is binary, you either develop diabetes or not, and not everybody's going to develop diabetes at the same time, that there's a time to event component. So you're likely to see Kaplan-Meier curves perhaps, and they may be reporting risks or percentages of patients with the outcome in the treatment group as well as the placebo groups. So with that, they can compute relative risk estimates. You could also do a relative risk reduction, which is 1 minus the relative risk, and it tells you, how much was the treatment able to reduce the risk of the outcome in the treated group compared to the outcome to the placebo group. Also, number needed to treat, which is nothing else but 1 over the inverse of the absolute risk reduction, which is the arithmetic difference between the risk of the outcome in the placebo group and the treatment group. So let's see what they did. And you've already seen this graph in Module 2, which gives us the cumulative risk of the outcome in the 3 arms. And as we went through one of the computations in that module, we saw that we could compute the relative risk of developing diabetes in the lifestyle group by comparing the risk of the outcome in the lifestyle group, dividing it by the risk in the placebo group. Well, they give you their primary results in Table 2. So let's see what they're presenting to us. Well, here is what I want you to focus on, the very first row, because that's the most relevant to see in the overall study what was the effect of lifestyle and metformin compared to the placebo group on the outcome, which is the risk of type 2 diabetes. So what they're giving you here is the incidence rate of developing type 2 diabetes in the 3 groups, as well as the reduction in incidence and the 95% confidence interval. So how do they come up with these estimates? Well, we can try out the math. So it won't be exactly the same with the numbers that they're reporting in the paper because they probably use some statistical software, but let's see what we can try to replicate. So here is so if I wanted to compute the rate ratio, I would have to do the following. So my rate ratio is the incidence rate of diabetes in the lifestyle arm, which is 4.8 per 100 person years, divided by the incidence rate of the outcome in the placebo arm, which is 11.0 per 100 person years. So you can see the person years disappear, and I'm left with 4.8 divided by 11, which if you whip out your calculator, you will see that it works out to be 0.44. So what are they reporting in this table? They're actually reporting 1 minus RR. So this is 1 minus 0.44, which works out to be 0.56. So you see what they're reporting is 58%, while we have a 56% reduction in risk. And so, like I said, this could just be due to, some other adjustments and during rounding off, since they're just reporting to us 1 decimal place here. So this tells us that compared to placebo, the lifestyle intervention reduced the risk of diabetes by 58%. And they're giving you a 95% confidence interval around that effect. You can see that metformin has a 31% reduction in risk, and lifestyle compared to metformin has a 39% reduction in risk. Now, to answer the question, are these statistically significant, you're trying to see, where are the p-values? Well, they may have reported that in their body of the results, but here you can kind of infer statistical significance by checking to see if the null value is in this confidence interval. And so here, if lifestyle had no impact on the outcome, we would expect 0%, which is the null hypothesis, to be in that interval. And 0 is nowhere close to this lower bound and the upper bound. And so we know that all of these effects are statistically significant at the alpha of 0.05 level. And so in addition, it tells us, these estimates are fairly precise. I'm not going to go into a discussion of these subgroup effects because we're not trying to do step 4 of our translation here, but this addresses their other research question, which is, does the effect of lifestyle and metformin compared to placebo, does it differ by age, sex, race, ethnicity, and so on, which you can see the subgroup effects might be very important when you're actually trying to translate these findings to the clinical setting. So if we go back and look at what the other questions we had for for identifying the source of random error, we can see that the magnitude of the treatment effects are clearly clinical significant. When you start seeing reductions as large as 58% and 31%, that is pretty huge. We've also seen that the results were statistically significant at the 5% level. The results were fairly precise. Did the study have adequate power, which in some ways is moot because they did find statistically significant findings, but they didn't know that starting the study. So we will see that in their method section, they do talk about sample size and power estimation. And what about multiple comparisons? So let's look at what they report here in their statistical analysis. And you can see here that, of course, they used ITT, but then they tell you that this blinded phase was actually terminated early. And if you recall, in Module 2, I mentioned that often randomized trials undergo what's known as interim monitoring. And one of the reasons for doing the interim monitoring is to ensure that no harm is being done, and in which case you need to stop the trial early. But once in a while, a trial may also be stopped because the benefits that they're seeing during the interim monitoring are so substantial that the trial needs to be stopped and the treatment needs to be made available to everyone. So that's what happened to this trial. It was stopped early because it was deemed through interim monitoring that they had, achieved statistical significance with about 65% of their planned follow-up, and they actually were able to ascertain statistical significance at fairly rigorous p-values of, as you can see, not 0.05, but even 0.0159. And you can see that for pairwise comparisons of outcomes, they also do a Bonferroni adjustment, which reduces the risk of having a false positive decision. So they tell you that their study design provided 90% power to detect a 33% reduction from an incidence estimate of 6.5, per 100 person years, with a 10% rate of loss. So they even accounted for, loss to follow-up in their sample size calculations. And clearly the effects they saw were even more substantial than a 33% reduction in risk. But that's what they had set out. They deemed that was clinically relevant, and at least they would have the power to detect that. And so I think we would all agree that this paper was, done well. It was designed and conducted in a manner that reduced the threat to internal validity due to sources of systematic error as well as random error. So, based on this, we believe that this study was internally valid, and, we could address the question of external validity to see can these results be applied. So this is where I won't belabor this because our goal was to stop here at critical appraisal. But if, for those of you who are curious, and I'll just spend the next couple of minutes doing partial translation, if we wanted to see now how we would go about applying this to clinical practice, I might, you might ask the following questions. So can these findings be applied to your patient? If yes, we won't really discuss how you might counsel the patient. But some of the things to figure out whether these findings are even applicable to your patient, you start looking to see, well, what are the features in this patient and how, are they incorporated in the description of the study sample in Table 1? And so we notice that she's a 43-year-old female with history of gestational diabetes, family history of diabetes, and these are her lab values, and this is her BMI. And if you look at these characteristics, you can see that, of course, they have females. The age range will also be captured. Her age is 43. Clearly, she will fall in, there are 43-year-olds in this sample. There are also women who have history of GDM. There are people with family history of diabetes. And again, her BMI as well as her lab levels are incorporated in this sample as well. So if you wanted to, and for those interested, you could try to sort of translate these findings. So I hope that with this series, we have achieved our objectives, and you are now fairly comfortable and confident in critically evaluating a clinical trial. Just know that there are many wonderful resources and critical appraisal tools out there that give you a checklist of questions. So you can certainly use those, but if you truly understand why certain design and features are important and critical for internal validity, I think you can come up with your own questions. And we hope that our motivation for making you aware of these critical appraisal tools has empowered you with the ability for you to come up with your own list of questions. And so you will always have the ability to critically evaluate a paper. So thank you so much, and good luck.